Hi, Professor.
Hello, Mazen.
How are you? Allow me to introduce you, please. It is with great honor and excitement that I welcome you all to this online lecture featuring our mentor and our inspiration, Professor Kypros Nicolaides, a true luminary in the field of fetal medicine, widely regarded as the father of modern fetal medicine. Professor Nicolaides has not only revolutionized the landscape of prenatal care, but has also been a guiding light for countless medical professionals around the world, including me and including Firas. His groundbreaking contributions has redefined our understanding of fetal health and reshaped the way we approach maternal fetal care. As a mentor of me and as a mentor of Firas, Professor Nicolaides has left an inedible mark on our hearts and our minds. His innovative research, compassionate approach, and unwavering commitment to advancing the field have paved the way for safer pregnancies and healthier lives. Please join me in welcoming Professor Nicolaides, a true father, our esteemed mentor, and an endless source of inspiration.
It is a great pleasure and honor for me to be able to address your meeting. I had promised Firas and Mazen that today I would be with you. Unfortunately, I cannot be. The last few weeks I have had a series of respiratory infections because I am having chemotherapy for multiple myeloma, and my oxygen levels were quite low, so I was not allowed to fly. I'm very sorry that I have not been with you, but I do promise you that in the future, hopefully, if I am in a better condition, I will come. I come from Cyprus, and I grew up with a very close love for the people of Palestine. As a child, one of our great heroes in Cyprus was your chairman, Arafat, and I always have your people in my heart. It was a great pleasure for me to be able to accept Firas and Mazen. So Basil, I cannot see him there. And only last week, I interviewed another doctor from Palestine who will also be joining us, the fellowship, quite soon. For the last few years, my topic of interest has been preeclampsia. I don't know if you can see the slides. Can you see the slides?
No. No, we can't.
Sorry?
No, we cannot see the slides yet.
You cannot?
No, we cannot.
Okay, let's go back, see what we can do. Share. And the slides must be the slides now. What about?
Yeah, now we are fine. Yes, we can see.
Mazen, can you see the slides now?
Yes, we can see the. You need to open the PowerPoint presentation, and we're okay.
Okay. My topic will be the prediction and prevention of preeclampsia, something that has preoccupied and concentrated our research for the last few years. And the reason for that is very, very simple. Preeclampsia on a worldwide basis is the main cause of death for women and their babies. More than 45,000 women every year die from preeclampsia, and more than 500,000 fetuses and neonates also die as a consequence of this condition. For those of you that are interested in reading the literature, I strongly recommend that you read this important review article that we published last year in the New England Journal of Medicine, which gives an overview on the prediction, prevention, and management of preeclampsia. When I was younger, the definition of preeclampsia was very simple. It was the development of high blood pressure and proteinuria in the second half of pregnancy. But as I got older, life became more difficult. And now preeclampsia has new definitions. You do not need to have proteinuria if you have some symptoms like pulmonary edema or blindness or eclampsia, or certain laboratory tests like low platelet count, high creatinine, and high liver enzymes. And there are two new, widely used diagnostic criteria. The one is by the American College of Obstetricians and Gynecologists, and the other is by the International Society for the Study of Hypertension in Pregnancy. And the criteria from the American College are more strict than those of the International Society. For example, the platelet count in the American College has to be less than 100, whereas in the International Society, it can be less than 150. More recently, in the International Society, they have also included fetal growth restriction. So if you have hypertension plus a small baby, that is also called preeclampsia. And very recently, like last year, they also included in the definition hypertension plus abnormal angiogenic markers. That means low maternal serum placental growth factor below the 5th percentile, or high split above the 95th. So we have this changing definition where in the traditional way we had eclampsia and gestational hypertension. Now, many cases of gestational hypertension are being classified as preeclampsia. They cannot see the slides. Can you see? I thought I installed that. Okay. Yes. What about now? Can you see the slides now? Now you can see the slides. Let me just go back again for 2 seconds. This is me. 46,000 women die every year, and 500,000 fetuses or babies die every year. And then I talked about these changing definitions of preeclampsia, where now you do not need to have proteinuria if you have hypertension, plus some symptoms or laboratory evidence of hematological, hepatic, or renal dysfunction, they're also called. Now, let us look at how do we go about predicting whether a woman is going to develop preeclampsia. In England, we are teaching, we are taught that when we see a woman at the beginning of the pregnancy, we must ask her 10 questions. And if the answer to the top 5 questions, anyone, is yes, then we say, aha, you have a high risk of getting preeclampsia. But if the answer to the first 5 questions is no, then we ask another 5 questions. And then if the answer is yes, 2 out of the 5, then we also say you're at high risk. The questions are the same in England and in Palestine and in America. And you are at high risk if you had preeclampsia in your previous pregnancy, or if you start the pregnancy with chronic kidney disease, chronic hypertension, diabetes, or autoimmune disease like systemic lupus erythematosus or antiphospholipid syndrome. The moderate risk factors are you are in your first pregnancy. In England, you are over the age of 40. But in America, because it's a capitalist country and they want to make more money, they say over the age of 35. In England, if your body mass index is more than 35, but in America, where everybody is fat, then if it's more than 30. And if the interval between this and your previous pregnancy is more than 10 years, if your mother had preeclampsia, and in America, if you're black or poor, and often if you're black, you are poor. This is a very simple way of predicting whether somebody has preeclampsia. It doesn't cost anything, just ask a few questions. But the real question is, how good is this method of screening that today, not 10 years ago, today, they practice in London and New York? How good is it? It's bad. It is as bad as screening for Down syndrome was in 1970. We classify as being at high risk 10%. 1 in every 10 women, we say you are at high risk. And this group that we classify as high risk only contains 40% of the women that will develop cancer. So we misclassify a lot of women and we miss most of the cases of preeclampsia. This is a paper they published before half of you in the audience were born. This is in 1992. And this is when I wrote that if you do an ultrasound scan at 12 weeks and you look behind the baby's neck, you can see a black space. And if the black space is little, it's good. And if the black space is a lot, it's bad. And that may indicate that the baby may have Down syndrome or other chromosomal abnormalities. Until that time, the method of screening was either to ask women, how old are you? Or to do a blood test in the second trimester and measure various metabolites. With maternal age as the method of screening, we used to classify 10% of pregnant women as being at high risk, and this group contained 40% of the babies with cancer. So in screening for preeclampsia, we are where we used to be 50 years ago. And then I proposed that in screening for Downs, we need to combine the information on maternal age and the biophysical test the measurement of fluid behind the neck, nuchal translucency, and the biochemical test, the measurement of liquid HG and PK. I have spent the last 30 years doing exactly the same way of thinking in the prediction of preeclampsia. We have developed the method of combining questions from the history together with the measurement of uterine artery pulsatility index at 12 weeks, the measurement of blood pressure, and the measurement of placental growth factor. And then the English government gave us a bit of money and challenged me to prove to them that our method is better. And we recruited 7 hospitals in London, 16,500 women, and we had a head-on comparison. The method that we use now, the NICE guidelines against the Fetal Medicine Foundation Cribble test, blood pressure, Doppler, placental growth. The Fetal Medicine Foundation is this blue, nice color, which is also here. And this is prediction, preeclampsia before 34, or 37, or after 37. And what did we find? That for each one of those types of preeclampsia, our method detected exactly twice many as the traditional. You would have thought that with this evidence, people would have already changed the method of screening. But you know, when I described nuchal translucency for Downs in 1992, in England, nobody wanted to believe that. But the women believed it, some of the doctors believed it, but the institutions, the government, the Royal College, did not believe it. It took 15 years and a lot of pressure from women, or the government was forced to adopt this method. It was only in 2006 that they asked me then to help the government to train all the hospitals in England to introduce the combined test of screening for Downs. How many years will now take? How many more women will die from preeclampsia before the governments that are preoccupied in investing in nuclear weapons can save some of the money to invest in the health of the population? 10 years, 20, 30, I do not know. We then were told that maybe this method only works in your hands. This is what they used to tell me in 1992. So we did studies in England, in Spain, Denmark, in many other countries. And these graphs that are called calibration and validation show that the method works well wherever you use it. What does this calibration mean in medicine? On the x-axis, we have the prediction of the model. We see a woman and we tell her that your risk of having preeclampsia is 1 in 2, or it's 1 in 1,000. How true is this number? Is it an invention of our brain? Is it real? We then examine many thousands of women and we look at the observed incidence. So if you have 100 women that were given a risk of 1 in 2, half of those women should develop preeclampsia. And if you have 1,000 women that are given a risk of 1 in 1,000, then out of the 1,000 women with this risk, only one should develop preeclampsia. And the perfect prediction is given by this diagonal blue line. And these are the results from the various studies. And you can see that the prediction is very, very close to the observed incidence. So the test works and it's accurate. This is the result from 5 different areas, regions in Spain. These are the results from 7 different countries in Asia, from Malaysia to Hong Kong, China, Singapore to Vietnam. And the test works. One question that people ask is that, do you really need to do the triple test, measure the blood pressure and the Doppler and the PLG? We are in Palestine, we are poor, but we are clever. We can measure the blood pressure and you can learn to do the Doppler, but you don't have money to measure PLGF. Is it necessary? Well, if we have the money to measure PLGF, then the detection rate of very early preeclampsia before 2 weeks is 90%. Of preterm preeclampsia is about 75%. If we don't have the money to measure PLGF, well, instead of 90%, the detection rate is 83%. Or if you're in a country where the doctors say we cannot do Doppler, but they are very rich. That country is called America. What can we do? Well, you should learn how to do Doppler, but if you are not very clever to learn how to do Doppler, don't worry about it. Use your money to buy PLGF. And then you can still do a lot better than without. That's one thing that you can. There's another thing that in screening, we can either fix the screen positive rate. We say we only want 10% of the population classified as being at risk, or we can say we will fix the detection rate. We want to detect 75% of the cases of preterm preeclampsia, and depending on which type of test that you use, then the screen positive rate may be lower or higher. So if you do not have the money to measure PLGF, but don't worry about it. Instead of classifying screen positive 10% of the population, you classify screen positive 15% of the population. If you're doing screening for cancer of the cervix, and you have this screening test where if you say it's positive, you need to do versatile hysterectomy, then you're very, very reluctant to have a very high screen positive. But if a consequence of a screen positive result is to give aspirin, well, it doesn't matter. You classify 10, 15% of the population as being screen positive. This is trying to predict preeclampsia. Now, what shall we do once we identify somebody as being at high risk for preeclampsia? In many different countries, the doctors have a disease, a psychological disease called put the woman in bed. There is nothing I know in obstetrics where putting a woman in bed helps anybody except the woman to go mad. I cannot think of any condition. But you go to all of these countries and you put the women in bed for 6 months, 9 months for no reason at all. Bed rest does not prevent preeclampsia. And then in some countries, like in Cyprus, maybe in Palestine, women are walking this big bag full of many, many different tablets. Because in our countries, we think that the more tablets you take, the better the doctor, and you are cured from all evil. There is no tablet that prevents you from getting eclampsia, except perhaps calcium and aspirin. Zinc, folate, vitamins, fish oil, omega-3, omega-99, nothing but nothing works. There is evidence from countries that are very low in calcium that if we take calcium, then we can reduce the rate of preeclampsia by about 50%. It doesn't really matter whether you give more than 1 gram per day or less than 1 gram per day. Because when I was diagnosed with multiple myeloma, you know, multiple myeloma breaks your bone. The doctors gave me these disgusting, big, white tablets where if you chew them, they taste like chalk. You know what is chalk? When we were students in the primary school and the teacher was writing on the blackboard, that is what calcium tastes like. I hated it. And then I stopped. My bones are all right. Now, the big problem is to identify who are the women that are deficient in calcium, because there's not a simple blood test you can do to measure calcium levels in the blood and then decide who should have calcium. But this is one method of treatment which has been shown in Latin American, for example, countries to work, perhaps. Aspirin. We have taken 27,000 women at first trimester screening by the Fetal Medicine Foundation method. We identified the high-risk group, and we randomized them into receiving aspirin, 2 tablets every day, 150 milligrams every day from 12 to 36 weeks, and placebo. And we found that in the group that received aspirin, we reduced the rate of early preeclampsia by nearly 90%, the risk of preterm preeclampsia by 60%, and there was no impact on term preeclampsia. What is also extremely important is that because we were reducing dramatically, 90% reduction of very early preeclampsia before 32 weeks, we were also reducing dramatically the length of stay in the neonatal unit. If you go to Palestine or to London, the majority of the babies that occupy beds in the neonatal unit are babies that are born before 2 weeks. So by giving aspirin and preventing early preeclampsia, we are actually reducing massively the cost of neonatal care. In England, the cost of neonatal intensive care is £2,500 every day. The government gives £1,000 for every hospital for the whole antenatal care and delivery. But every day the neonatal unit is £2,500. If you stay in the neonatal unit for several days or weeks, the cost per baby is £100,000. You buy a house for £100,000. And it's much worse than that. The babies that stay in the neonatal unit who were born before 32 weeks, they have a lot of handicap. And if you look at the whole life cost of somebody that was born before 32 weeks, it has been estimated that the cost for a country like England is £3 billion every year. Children that grow up because they were born very prematurely. So this is a very important consequence for proper prediction and prevention of preterm preeclampsia. Let us now talk a little bit about term preeclampsia. If a woman today in Jerusalem develops preeclampsia at 26, 27 weeks, there's a high risk that either the woman or the baby will die, and then the husband will be very angry, and then he will also kill the obstetrician. If a woman develops preeclampsia at 40 weeks, who cares? Just deliver the baby and nobody dies. Is that true? Preterm preeclampsia is important. Term preeclampsia is not important. What is absolutely true is that the incidence of severe hypertension in the mother, maternal mortality and severe morbidity, perinatal mortality, neonatal unit admission for more than 48 hours, and very low birth weight are much more common in the babies that are born prematurely than in those that are born at term. Blue, premature, red, term. However, this is only half the truth, because there is a lot more babies that are born at term than preterm. The incidence of preterm preeclampsia is only about 0.7%, whereas term preeclampsia is 3%. So although the incidence of complications for the mother and the baby is higher, the preterm than term group, the contribution of term preeclampsia is greater than that of preterm preeclampsia. So term preeclampsia is important for the mother, severe hypertension, maternal death, severe morbidity. The high proportion of perinatal mortality and morbidity can also be attributed to delivery at term. So it's not a condition to be ignored. But we have a problem, isn't it? First trimester screening by the Fetal Medicine Foundation triple test identifies only 40% of the term preeclampsia. And aspirin has no effect on term preeclampsia. So what can we do? We need to screen for term preeclampsia nearer the disease. If I want to predict what is the weather in Jerusalem tomorrow, it is much more likely that I will get it right if I make a prediction today than if I made a prediction 3 months ago. And the same is true for the prediction of preeclampsia. If you want to define who is at risk of term preeclampsia, we need to screen at 36 weeks. And this is from many studies that we have done, and the latest is nearly 30,000 women, which shows, again, prediction validation of screening at 36 weeks. In the first trimester, the triple test, blood pressure, uterine artery Doppler, placental growth factor. In the third trimester, uterine artery Doppler is useless in the prediction of term preeclampsia. So now the triple test of the third trimester, blood pressure, placental growth factor, and FLEET. We then did a big study of nearly 30,000 women. We identified the high-risk group, and we gave them study. I take statin, all people take statin, because it stabilizes your endothelium and it reduces your risk of cardiovascular disease. And since preeclampsia is also an endothelial dysfunction disease, we thought that giving statins would be useful. Unfortunately, it was not useful at all. The placebo are the blues, the pravastatin is the reds, and there was no difference between them. Very disappointing. And I can assure you, it's a lot of work and money to the study involving 30,000 people. Maybe it was too late. So what can we do next? It was a nice study in Chicago by this nice guy, Hoffman, who took low-risk nulliparous women at 38 weeks, and he randomized them into two groups. One group, he said, you're low risk, your first pregnancy, we let you carry on until you deliver. In the other group, he delivered them at the beginning of the 39 week. There was no difference between the two groups, the early induction against the expectant in perinatal death, but contrary to expectation, the rate of cesarean section was less in the early induction than the expected management. Also very important was that the incidence of high blood pressure disease was substantially lower in the induction than the expected management. So we have now been doing a study, and we recruited 2,500 women in the trial. I need 4,000, so I will finish by Christmas, where we do screening at 36 weeks in all women, placental growth factor, fluid, blood pressure. We calculate the risk, and if the risk is very, very high, we deliver these women at 37 weeks. If the risk is less, we deliver them at 38, 39, 40, so on. We have estimated that by this strategy, we will reduce the rate of term preeclampsia by at least 60%. And it's not only term preeclampsia that we reduce, we reduce gestational hypertension, we will reduce fetal distress labor, and I believe that we will also reduce neonatal morbidity. But we will see. Next time I come to Jerusalem, I will tell you the end of the story. What about twins? Nowadays, 2% of women have twin pregnancies. And as women get older, or they have babies, or as more and more women have infertility treatment, the incidence of twins goes up. We know, and have done several studies, that the relative risk of preeclampsia in twins is 3 times. The incidence of preeclampsia in twin pregnancies is 3 times higher than in singleton pregnancies. But this is only half the truth. Because of course, twins deliver mostly premature. So if I want to have a fair comparison of twins against singletons, I must not look at the whole incidence of preeclampsia, but at the incidence of preeclampsia in preterm baby. And then the incidence in twins is 9 times higher. So all twin pregnancies have a higher risk, substantially higher risk of developing preeclampsia. What can we do in these women? Unlike singleton pregnancies where we prove that aspirin is useful, we don't really know that aspirin is useful in twins, and it is not good enough to say, well, it is good in one, it should be good in the other. And therefore, having this monster study, which starts off with 250,000 people to identify those that carry twins and randomize them, those that have twin pregnancies, into aspirin 150 milligrams against placebo, and hopefully find out if aspirin is also useful in this condition. We will know that answer in 3 years. 3 years. Let me now come to the end of my lecture and summarize which are the best ways to identify women at high risk of developing preeclampsia. The measurement of blood pressure is always useful. 12, 20, 30, 36 weeks, always useful because, of course, preeclampsia is a disease of high blood pressure. Uterine artery Doppler, which is giving you information about impaired placentation, is only useful for preterm and early preeclampsia, not for term preeclampsia. Placental growth, which is a measurement of placental function, is during the first and the third trimester. The anti-angiogenic factor called FLIT only goes up 3-5 weeks for the clinical onset of preeclampsia. Therefore, it's not a good method of screening at 12 weeks, but it's useful in identifying women that have imminent development of preeclampsia. HAB-A is a bit, we got PLGF, but it's not really. Women that get preeclampsia have 3 times a higher risk of dying in 10, 20, 30 years from brain hemorrhage and cardiac disease. And the real question is, does preeclampsia damage their blood vessels and their kidneys and their heart? And that's why they die of cardiovascular disease. Or, more likely, women that get preeclampsia, they do so because already they have predisposition to cardiovascular disease, and preeclampsia is a pure stress test which manifests this underlying cardiovascular disease. In any case, just in case it was useful to predict preeclampsia, we carried out big studies. In this study, nearly 5,000 women at the routine 20-week scan had maternal echocardiography. The vertical black line shows normality. The horizontal lines show different cardiac functions in women that develop preeclampsia. You can see that most of them are normal. Only one thing was very abnormal from 20 weeks, and that is peripheral vascular resistance. So these women that will develop preeclampsia already have a vascular disease. That is why they die 20 years after preeclampsia because of this vascular disease, heart attacks and strokes. So, can we use vascular resistance as a predictor of preeclampsia? Well, it's not so easy to teach all obstetricians of the world do maternal echocardiography. But there's another way. Unfortunately, the videos with these things don't work. There's another way where you can measure peripheral vascular resistance. This is very easy, and many people in Palestine can do that. A woman is lying in bed, take a transducer, ask them to close their eyes, and you put the transducer on their eye, and then you get this very interesting waveform. 2 peaks systole, then diastole. Then you say, but what is this double peak? Blood goes up into the aorta, then into the brain, and the ophthalmic artery. The blood vessel that supplies our eye, the first branch, the internal carotid artery. So the heart contracts and bam, the blood goes up and you get the first systolic wave. But this systolic wave then goes to the periphery, and if you have small vessels in the periphery, it gets reflected and it comes back from the periphery into the heart and up into the brain and into the ophthalmic artery. So the first wave, the reflection of cardiac contractility. The second wave is a reflection of peripheral resistance. We have done studies at 36 weeks and 20 weeks and 12 weeks. The blue line, horizontal blue line, is normality. The red circles are from women that subsequently developed preeclampsia. You can see that whether you look at the first, the second, or the third trimester, a lot of the women that will develop preeclampsia have increased in this ratio of the second wave, the peripheral resistance wave, divided by the cardiac output wave. So this, to me, is a very simple test that we can easily do on everybody. I am coming to the end of my lecture. A very nice Indian guy. When you look at him, he looks a little bit old, he looks a little bit thin, he looks a little bit miserable. I spent the last 15 years developing a very simple test. Just have this very little thing, that's much smaller than a computer stick, and you push it into your hand, you get a drop of blood, then you do nothing. You have some water to drink because you talk too much. And after 10 minutes, you put this thing in this small reader. It's just like a computer, a pocket phone, and then it gives you a measure of glycosylated fibronectin. We have now done studies in the first and the third trimester. We found that in women that will subsequently get preeclampsia, red circles, the glycosylated fibronectin is already increased, and therefore, for people in America where they don't learn how to be an artery doctor because it's too complicated for them, they can perhaps do an ophthalmic artery doctor, and you get the same performance of screening. And also in the third trimester, where you may not have enough money to buy PLGF and FLIT, maybe the glycosylated fibronectin would be a simple replacement of that. So I want to finish with this slide of this beautiful black woman. She was an Olympic athlete, Rory Bowie. She got the gold medal in the Olympic Games. And 3 months ago, they found her dead at home at 32 weeks, and she died of preeclampsia. So preeclampsia is a nasty condition. It kills people, it kills women, and it kills their babies. And today, we have good ways to identify the high-risk group, the first and the third trimester, and have interventions that can prevent. We need to pressurize governments to spend less money on developing methods to kill people, a little bit more developing methods to save. And we need to educate obstetricians that it's worthwhile in producing methods of prediction and prevention of preeclampsia. I thank you very much again for the great honor and pleasure to be with you today.
Thank you. Thank you, Professor. Thank you very much. Thank you for having the time to give us this amazing and insightful lecture. And thank you for all your work you've done. And thank you very much again. Thank you for your time.
Mazen, I don't know if anybody wants to ask any questions or if it's already too much.
Do you have any questions? Thank you, Prof.
Enjoy yourselves.
Thank you. Thank you very much.